What we do is we do a very comprehensive review of all the studies to date on C15, and we tie that to our experimental studies over the past 10 years. And where they consistently land is that people who have less than, or dolphins that have less than or equal to 0.2% of C15 in their cell membranes, we're defining as having a nutritional deficiency, and they're undergoing accelerated aging. This is when cells become susceptible to ferroptosis. And it really feels like a threshold. So it's like literally you're standing at the edge of a cliff, right? If you're right at the middle of a 0.2% of C15. And if you take one step off and you lose that amount of C15, the cell membrane becomes fragile. Ferroptosis. This is what we saw happen in the dolphins and as well as in the models. If we have greater than 0.2 to 0.4% of C15, then we're calling that nutritionally replete and that you are aging normally. Most people are standing on the cliff. So most people today are at 0.2% of C15 in their red blood cell membrane. Then we have encouraging science that shows from others that show that this going from getting to a 0.4 to 0.64% of C15 may actually be optimal, and that may actually slow aging better than what we have understood in the past. I'll provide the science on that front. So our C15 levels have been declining, and why, right? So it's because our primary source of C15 is from whole fat dairy products. And since 1977, right, we've been told to decrease our intake of whole dairy fat, specifically to decrease our intake of saturated fats, including C15. That has resulted in declining C15 levels. So back in 1950s, we drank an average of 2 cups of whole fat milk per day. And that is now down to about a half a cup of milk, not even whole fat milk. So non-fat milk has no C15 in it. So we've seen a dramatic decline. That has coincided with a decline in circulating C15 levels over time, where we've gone from a 0.23 down to this 0.2, and this was from 2011. So likely, like right around, if not below this level, is where really the world is now sitting. So it's not just because of decreased whole fat intake, though that's the primary driver. We now also know that how much C15 that is present in milk is changing, and that if a cow is fed corn, it has half as much C15 in its milk than a cow that is fed grass. So grass-fed, dairy products coming from grass-fed cows are better. And there are even more encouraging studies showing that animals, ruminants that are fed grass at higher altitudes, so mountainous grass, they have twice as much C15 as the sea level grass. So there are some actionable items in the industry that we can do to help get C15 levels back into our food supply. Additionally, our C15 levels go down as we age. So we're still trying to figure out why, if it's decreased absorption, eating less, but we do know that C15 levels go down as we age. Could that then be accelerating the aging-related breakdown? We argue likely. So this is a graph showing Sardinia, and we'll get back to Sardinia as well, but this is a high longevity zone. And Sardinia Sardinia has some of the longest, like it's this blue longevity zone. It's where most men live beyond 100 more than anywhere else in the world. And it's been attributed to they have a lower risk of dying from heart disease. And so in Sardinia, they have, even our 60 to 75-year-olds have C15 levels that's 3 times higher than we see around the rest of the world of 0.6. Even the 80-year-olds, it's lower, but it's 0.4. And then what they called their reference low longevity zone, which is going to be us, apparently, is at that 0.2%. So we'll get back to that in a second. So then let's talk about cellular fragility syndrome. So what we share in this paper is that C15 deficiency causes cellular fragility syndrome. And again, this is the first nutritional deficiency described in 75 years since vitamin B12. So the way this plays out, the pathophysiology behind it, is that if we have less than 0 or equal to 0.2% C15 in our cell membranes, that makes us susceptible to cellular fragility syndrome. What happens is our red blood cell membranes become fragile, and this results in lipid peroxidation. When our red blood cells become fragile, then our macrophages in our liver, the Kupffer cells, then go to work, right? So they detect fragile red blood cells and they engulf those red blood cells, the weak ones, into the liver. And normally their job is to then just recycle the red blood cells and the iron. But if you have too many weak red blood cells and it's taking in a lot of those weak cells, that results in what's called dysmetabolic iron overload syndrome. And this is what we found was happening with the dolphins, that the red blood cells had become weak due to low C15. They were developing iron overload in the liver, and that resulted in visible iron and driving dysmetabolic iron overload syndrome. This then contributes to ferroptosis, that then has the downstream effects of first liver. So what's unique about this, and Jeff Schwimmer, who's a leader of NAFLD, pediatric NAFLD here at UC San Diego, he's like, I knew it. He's like, I knew it was all about the liver, that when we see the metabolic syndrome coming from this, it starts at the liver because of the injury that's happening due to ferroptosis in the liver, resulting in insulin resistance, hyperglycemia, dyslipidemia, NAFLD progresses to NASH. We get chronic inflammation. That then spills over, the iron spills over into the blood and then affects our other organs, leading to higher risk of direct damage to the heart, as well as in the brain. We aren't talking a lot about the brain. We'll have a lot more on that front next year. So cellular fragility syndrome, when you talk about how do you detect it in your patients, that there is now, and Genova Diagnostics offers an at-home C15 test that then allows, and it specifically measures C15 in the red blood cell membranes, which is exactly what you want. So having low, and they report it in percentage as well as in micrograms per mil. So you can find this amount. So that's the first part. Fragile red blood cells can be detected because you can still have fragile red blood cells that have normal red blood cell count as long as your production keeps up with the loss, right? So elevated red blood cell distribution width is a huge sign, not specific, but it is consistently part of this syndrome. Elevated reticulocytes and elevated osmotic fragility. I wish that test was more widely available. It directly tests the strength of the red blood cells, and you may or may not see low hemoglobin. Once it advances enough, that's when a low hemoglobin and anemia kicks in, and why we're arguing so many people who are older have anemia of unknown cause. This then, you can detect the iron overload component with hyperferritinemia, of course, ruling out chronic inflammation as the cause, but it's a hyperferritinemia that can have a normal total iron binding capacity. For ferroptosis, you can detect high lipid peroxidation products, specifically T-bars, and again, this high ferritin. And then once we move to the states where it's affecting the liver and the heart, then that's where we see the elevated glucose, cholesterol, triglycerides, liver enzymes, and specifically high IL-6, TNF-alpha, and MCP1. This is what the dolphins had. They didn't have any variation. Every dolphin had this picture. And so we were gifted with this. Not every person who has NAFLD has cellular fragility syndrome, and not every person who has cellular fragility syndrome develops these diseases. But as we get familiar with this mix of diagnostic tests, it may help with regard to seeing things that could be driven and caused by this disease. So that getting toward the end to be able to take questions, the big thing is that, this is fixable. The upside of a nutritional deficiency syndrome is we can detect it and we can fix it. So we now know that most people need an added 100 to 200 milligrams of C15 per day to not be deficient. Our bodies can make some C15, and that's specifically with microbes in our gut. that can make some C15, but it doesn't appear to be enough. So most people, which is why most people are sitting right around that 0.2%. Some people who are strict vegans, we've seen levels as low as 0.04, 0.02%. So they would need more. But most people need a conscious add of 100 to 200 milligrams of C15 per day. And what we've shown, importantly, is that adding C15 back, right, reverses cellular fragility syndrome. So we can replenish healthy C15 levels to restore long-term health. So if we can get up and over 0.2% of circulating C15, cellular stability comes back. We results in normal hemoglobin and normal red blood cell distribution. This is a remarkable fix. It happens within weeks. Where the anemia is alleviated within 3 to 6 months. We see a decrease. In fact, it stops a deposition of iron in the liver. Again, these are in relevant models. And we may or may not see lower ferritin. It's not helping to take the iron out that's already in the liver. It's just helping to stop it from accumulating further. It stops ferroptosis and all of the components of it. And downstream in relevant models, and now in these clinical trials, we're seeing healthier liver, leading to lower glucose, lower triglycerides, lower liver enzymes, lower LDL cholesterol, and pro-inflammatory cytokines, and improved cognition. Again, I'm going to hold on that one. It's encouraging early data, but all these other areas have much, much more robust, healthy data to talk about patients. So optimizing C15 for longevity. So now saying, okay, now we can fix C15 levels and get back to where we're supposed to be. Is there potential to go from that 0.4 to 0.64% to get to an optimal state? And so that's where we have one study by True et al., by folks at Stanford and other places, where we can see that the higher the C15, a prospective cohort study, the lower their risk of developing cardiovascular disease. So if you have C15 greater than 0.4 to this kind of 0.55%, they had the lowest risk of cardiovascular disease. That matches with, again, this longevity blue zone of Sardinia, where they have lower risk of dying from heart disease, the longest lived male populations in the world, and they're sitting on this 0.4 to 0.6%. Why not just eat more dairy fat? Well, we could, and we argue that children should probably go back to being able to get whole dairy fat in their earliest stages. But for us, over decades and decades of life, dairy fat only contains 1%. Milk fat only contains 1% of C15, while we have it contains greater than 40% of pro-inflammatory fats, these even chain saturated fatty acids. There's a less bioavailable, it's in a less bioavailable triglyceride form, and it's highly variable C15 content based upon what I shared earlier. We don't know what's in that milk anymore because we don't know what the cows were fed, the season, the altitude in which they were fed grass. So that's where optimizing nature to extend healthy aging and longevity. How can we push science to make use of nature and be able to see if we can get to that 0.4 to 0.6%, not just for the folks living in Sardinia. And that's where a pure C15 free fatty acid may be the way forward, and based upon input from a panel of experts that met, and they said when it comes to dairy fat, it does seem that the individual nutrients, ingredients within dairy fat do better on their own versus when provided as a whole. And this is an exception to the general rule where it's better to get your nutrients by eating the whole foods. This group concluded that for dairy fat, that may not be the case. Yeah, the Sardinians have their own goats and sheep, and it's in a mountainous regions. So they make pecorino cheese, but pecorino cheese has 2 times higher C15 level than even cow's butter. That previously was the highest C15. So we now know how Sardinians are getting high C15 levels, but it's not just because it's from goat. It's because the goats are grass-fed, they're local, and they're feeding off of mountainous grass. But I will share, you can nerd out on the science.